Good day, future RMTs. In this discussion, what we are going to discuss is all about therapeutic drug monitoring. Our learning outcomes are as follows. Number one is to determine the fate of drugs in the body from the point of entry up to the time of excretion, and then identify the samples for evaluation of drug and poison toxicity, which we are going to discuss further in toxicology. To start with, let us start our discussion with anti-lipemic drugs. As we all know, when dietary fat is taken into the body, it is absorbed in our small intestine to form our triglycerides and our cholesterol. These are the two main components of the lipids in the body. Remember that triglycerides are the energy source in the adipose tissue, while cholesterol is incorporated into circulating proteins called lipoproteins, and it is transported from the intestine to the liver. The transportation of this cholesterol bound to the protein to the liver will be used for synthesizing steroids used for endocrine system, such as the bile needed for our food absorption, and as well as the cell wall synthesis. There are two major, what do you call this, mechanism, no, for this one. Okay, the transport of cholesterol and the triglycerides in the body in the participation of what we call lipoproteins, apolipoproteins, no, which are the component of the lipoproteins, receptors, and enzymes. Remember, guys, that cholesterol is a uh, endogenous, no, substances, which means that is a naturally occurring. Normally, the body of an individual manufactures enough cholesterol to meet the metabolic requirements of the body. However, aside from cholesterol is being a natural agent or a natural substance, it can also be taken from dietary sources such as food, no, rich in cholesterol or precursors of cholesterol. Okay, for example, or a condition, no, that can lead into what we call increase in our cholesterol production. Let's say, for example, no, excess dietary carbohydrates are converted into triglycerides, which is a precursor of our cholesterol. Okay, we have also what we call this condition hyperlipidemia. And what does it mean? When we said hyperlipidemia, it is an abnormal elevation of the cholesterol and triglycerides level in the body. Hyperlipidemia can be due to genetic disorders or can be due to uh, secondary cause. No? Let's say, for example, lifestyle, drugs intake, and underlying diseases. Okay, so these are the two reasons why patient or why people would have a hyperlipidemia. Number one, it is because of the genetic abnormalities, and number two, because of the secondary causes, which includes the lifestyle, the drugs, no, the intake of drugs, and the underlying diseases of the patient. Aside from that, aside from genetic alone or other conditions or secondary conditions, a patient may develop hyperlipidemia due to both problem in the genetics or genes, and of course to secondary causes. Okay? Remember, a highly saturated fats, cholesterols, and carbohydrates, and as well as alcohol, coupled with the sedentary lifestyle of an individual, which is a great contributor of developing hyperlipidemia. There are treatment, no, for hyperlipidemia. You can undergo dietary component treatment and of course drug component treatment. When we said uh, dietary component treatment, it includes the reduction of weight, exercise, and diet in the cholesterol. Okay? According to the American Heart Association as well as the National Cholesterol Education Program, no, the recommended fat intake should be reduced to less than 30% of the calories so that an individual will have a low risk of developing hyperlipidemia. Okay? We have classes of our lipoprotein disorders, no? These are treatable with diet and drug therapy, which includes familial hypercholesterolemia, polygenic cholesterolemia, familial hypertriglyceridemia, and mixed hyperlipidemia. Okay, opposite to this dyslipidemias are the abnormalities in the lipid profile, all of which are all, or most of them are all problem in the lipoproteins, particularly in the low density lipoprotein cholesterol. While familial hypertriglyceridemia as well as mixed hyperlipidemia are a problem that involves the triglycerides. And since these are treatable with diet, and aside from that, drug therapy, there are single drug dependent treatments and a drug combination drug treatment. Remember that drug therapy for hyperlipidemia, no, can include the use of statins, the use of niacin, and the use of bile acid resins. Okay? Now, when we said niacin is an effective in lowering total cholesterol and record success in lowering the cholesterol levels. No? Particularly, the triglycerides, the total cholesterol, the triglycerides, and aside from it lowers the triglycerides and the total cholesterol, niacin increases the high density lipoprotein, which is known to be our good cholesterol. On the other hand, we have your statins, which are highly effective in lowering our low density lipoproteins and relatively safe naman. Okay? So for the combination of the drugs, we have the bile acid and niacin for familial hypercholesterolemia. It also involves bile acid resins and statins, as well as niacin and statins. For polygenic cholesterolemia, we have your bile acid and niacins, bile acid resins and statins, niacin and your statins. Okay? Now, here are the bile acid binding resins. We have your cholerestamine and your cholestipol. Remember guys that bile acid resins or bile acid binding resins are drugs, no, that binds the bile in the intestine. Therefore, after the ingestion, the resin from the absorbable complex with the bile acid prevents the enterohepatic recirculation, recirculation of the bile acids. Thus, it will result to the removal of the bile acids. Okay? Remember also that these bile acid binding resins are used with dietary therapy to decrease the levels of our cholesterol, particularly in type 2 hyperlipidemia. Okay? However, the use of this one can be useful also to provide to secondary to partial, what you call this, partial biliary stasis. Okay? So we have here your cholestyramine, which is given orally 4 milligrams 1 to 6 times a day, and if that will be given as a maintenance 8 to 16 grams per day, maximum of 24 grams per day. Okay, and the therapeutic outcomes of this drug will reduce the LDL and the total cholesterol levels. However, there are side effects in the use of this drug, which includes constipation, bloating, fullness, nausea, and flatulence. And the drug interaction of cholestyramine includes resins may bind to warfarin, thyroxine, thiazides, diuretics, phenobarbital, NSAIDs, or non-steroidal anti-inflammatory drugs, which are commonly referred as our pain reliever, tetracycline, and amiodarone, and beta blockers. Aside from cholestyramine, we have your cholestypol, which is given 5 to 30 grams in granules per day, divided in doses with the initial dose of 5 grams given 1 to 2 times a day. It is also capable of reducing the total cholesterol as well as the HDL and can cause constipation, bloating, fullness, nausea, flatulence. The side effects of this drug, which are almost synonymous to the side effects, no, of cholestyramine. Okay, the drug interaction is almost synonymous to our cholestyramine. On the other hand, we have our nicotamic acid, which is also a bile acid resin, no, which is given initially at the dose of 100 milligrams with meal, no, with meal. And then, after meal naman, PC means after meal, 1 to 3 grams per day in 3 divided doses, which usually dose is 3 to 6 grams daily. Aside, this is a powerful, what you call this? Let me correct this one. Dito bile acid. This is a niacin. Yan. This is a niacin. Kindly correct. Okay. This niacin drug is capable of reducing, no, the VLDL and LDL types, no, 2, 3, and 4, phospholipids and total cholesterol, as well as the triglyceride levels and increase HDL levels. Take note that this drug, niacin, okay, a drug class of our hyperlipidemia drug, this drug is also known as your nicotinic acid, which is a water-soluble vitamin B, which inhibits the VLDL synthesis by liver cells, causing the decrease of LDL as well as our triglycerides. Okay? Aside from that, it can be used with statins and bile acid binding resins for a greater combined lowering of our cholesterol level. One of the best thing for niacin or this drug is it is not costly or expensive. Okay, however, niacin is not recommended for diabetic because of the side effects, no, nagkakameron ng glucose intolerance. Thus will greatly affect the glucose metabolism of an individual. Moving forward to our next drugs that we're going to discuss are the antihypertensive drugs. Remember guys that our heart facilitates the circulation of the blood to tissues and organs, and that is the major role of our heart, no? Now, remember that when heart contracts, the blood is pumped throughout the body, okay? Throughout the circulation, okay? Aside from that, no, aside from the circulation, no, to the different tissues. Remember guys that heart contraction generates pressure. That is what we call the blood pressure, no? Yung uh, systolic, no, and the diastolic. Now we have what we call the arterial blood pressure or the systolic blood pressure. And we also have our diastolic blood pressure. Okay? Remember guys that the arterial blood pressure is defined as the heart contraction that generates pressure when the blood is pushed, no, out of the heart. When the blood is pushed out of the heart, that is what we call the arterial blood pressure or the systolic blood pressure. On the other hand, when the heart remains relaxed or when the heart relaxes between contraction, the blood pressure drops to the lower level, and that is what we call the diastolic blood pressure. Now, we also have what we call the pulse pressure. And what does it mean? When we said pulse pressure, that is the difference between the diastolic blood pressure, no, that's the difference, Now, this is the difference of systolic and diastolic blood pressure. Okay? We also have what we call the mean arterial pressure. What does it mean? When we said mean arterial pressure, it is the average pressure throughout the heartbeat cycle. And aside from that, it is significant because uh, it can it can it is significant because the pressure that actually pushes the blood through the circulatory system or through the circulatory system to perfuse tissue. Okay? Now, there are underlying conditions or normal, not underlying, there are normal conditions, okay, which affects or which contributes to our arterial blood pressure. We have your uh, cardiac output, okay, which includes the stroke volume, the heart rate, and the venous capacitance. Okay, what do we mean by arterial blood pressure? Take note that arterial blood pressure is almost synonymous to systolic blood pressure. Okay? Now, arterial blood pressure is a output or it's a product of what we call cardiac output. No? Arterial blood pressure is a product of cardiac output and our peripheral vascular resistance or what we call the PVR. Remember guys that cardiac output or CO is the main determinant of the systolic blood pressure. Now, it is determined by what we call the stroke volume, heart rate, and venous capacitance. When we said stroke rate, that's the volume of the blood ejected into a single contraction of the left ventricle. Okay? And usually indicated as ml per minute, an average of 4 to 8 liters per minute. How about the heart rate? The heart rate is controlled by autonomic nervous system, while the venous capacitance is the capacity of the veins to return blood to the heart. Okay? Remember people that systolic blood pressure is increased by factors that increases the heart rate and stroke volume, while venous capacitance affects the volume of the blood that is returned to the heart throughout the central venous circulation. Now, we have what we call hypertension. Hypertension is a condition characterized by elevation of the systolic pressure, elevation of diastolic pressure, or elevation of both systolic and diastolic pressure. Okay? Now, we have two types of hypertension. We have the primary hypertension and we have the secondary hypertension. The table that I am showing to you is the JNC classification of hypertension. No? Let's say, for example, the normal is less than 120 systolic blood pressure and the diastolic blood pressure is less than 80. 120 over 80 is considered no normal, or less than 120 over 80 is considered normal. However, there are conditions naman na tinatawag nating hypotension which is not also a normal condition. Okay? I've discussed this already to you in Clinical Chemistry 1, so we're going to skip that. But we're going to give emphasis on what we call primary and secondary hypertension. When we said primary hypertension, that is usually idiopathic, unknown cause or unknown case, no? Aside from that, it is incurable. Okay? While secondary hypertension occurs with another, no? disorders developed by the body. Let's say, for example, renal diseases, okay, uh, trauma, diabetes, no, or Cushing syndrome. Now, there are what we call hypertensive drugs. No, we have our preferred agents, we have our alternative agents, and we have our adjunctive agents. For preferred agents, we have your diuretics and your beta adrenergic blockers. For alternative agents, we have your ACE inhibitors, the angiotensin 2 receptor antagonist, the calcium ion antagonist, and the alpha 1 adrenergic blocker. For adjunctive drugs, this includes the central acting alpha 2 antagonist, no? We also have your peripheral acting adrenergic antagonist, and we also have your direct vasolators. Now, let's discuss first the preferred agent, which includes your diuretics. Diuretics act by causing volume reduction, sodium excretion, and vasodilation of the peripheral arterioles. As we all know, if there is an increased amount of water, which is proportional to the amount of sodium, ibig sabihin, it can lead into what we call hypertension. That's why this diuretics promotes the losing of this excess volume as well as the secretion of our sodium in the body. Okay? And there are four major types or four major classes of diuretics. These are your carbonic anhydrase inhibitors, which have a weak anti-hypertensive effects so that it is not usually used. We also have your thiazides, no? We also have your loop diuretics and potassium sparing diuretics. Okay? Take note guys that potassium sparing diuretics are rarely used alone. Okay? This is usually combined with our thiazides. Okay? Or the loop diuretics. The purpose of that is to have an anti-hypertensive effects to have a counterpart for potassium excreting effects of this drug. Aside from that, I want you to take note that diuretic drugs are the most commonly used or most commonly prescribed antihypertensive drugs. Why? Because of its capability to reduce morbidity and mortality associated to hypertension. We also have what we call the blocking agents. What do we mean by blocking agents? Blocking agents now inhibits the response of our sympathetic nerve stimulation by blocking the beta receptors. Okay? Usually it produces a reduction in heart rate, cardiac output, and of course, blood pressure. Okay. However, the clinical advantage of this one, no, is being recommended because of the minimal slowing, no, of the central nervous system. Now, there are side effects of using the blocking agents such as your beta adrenergic agents. What are those? It can lead into what we call bradycardia, peripheral vasoconstriction, purpling or mottling of the skin, bronchospasms, squeezing, no? Diabetic patients no should be monitored for hypoglycemia. Aside from that, headache, nausea, vomiting, weakness, no? And aside from the side effect of this one, no, aside from those, heart failure manifested with edema, dyspnea, bradycardia is also seen to a patient who is taking up your blocking agents. Next in line is we have the ACE inhibitors or the angiotensin converting enzyme inhibitor. As we all know, our angiotensin 1 is produced in the body, no, which are inactive. That's why we have to convert it to its active form using the enzyme ACE. However, since there is a problem in the RAAS system, ano yung nangyayari? We have to suppress the conversion of your angiotensin 1 to angiotensin 2. Why? As we all know, no, meron siyang effect of increasing the vasoconstriction, no, aldosterone production, water retention that can lead into hypertension. So, ang main na ginagawa ng ACE inhibitors is to block the conversion of angiotensin 1 to angiotensin 2. And aside from that, it represents the major breakthrough in the treatment of hypertension. Okay? Because as we all know, renin angiotensin aldosterone system plays a major role in the regulation of what we call hypertension. Okay? And aside from that, we have what we call the calcium ion antagonist. Okay? We have your calcium ion antagonist. This drug inhibits the movement of calcium ions across the cell membrane. Okay? This may result in fewer arrhythmias, slower heart rate or rate of contraction of the heart, and relaxation of the smooth muscle of the blood vessels. There are 4 classifications of calcium ion antagonist. We have your benzodiazepines, which includes diltiazem. We also have what we call diaminopropanolol ether, which includes bepredil. We also have what we call the phenylalkylamines. Example is the verapamil or the verapamil. And of course, we have what we call the dihydropyridines, which includes the amlodipine, no, felodipine, isradipine, nicardipine, nifedipine, lahat ng may pin, okay, are example of dihydropyridines. Okay, so let me write those things. Okay, so these are our calcium ion antagonists. Okay, one of the major side effects of our calcium ion antagonist is the hypertension and the synop. Okay, okay, so the next drugs that we are going to discuss are the drugs for heart failure. Remember that heart failure is also known as what we call the congestive heart failure. It is consists of clusters of signs and symptoms due to inability no, of the heart to pump enough blood to meet the body's circulation. Since the heart is not capable of pumping the blood, there will be a congestive, which leads into what we call heart failure. Now, there are several causes of heart failure, but the major or the most common causes of this heart failure includes our systolic dysfunction and diastolic dysfunction. In our systolic dysfunction, that is the most common source or the most common problem of our heart failure. The heart is unable to contract enough to force no the pump to pump all the blood, which lead into what we call decrease in the cardiac output, with which it is represented, no, to meet the body's oxygenation needs. Thus, therefore, it can lead into what we call decreased tissue perfusion. Now, okay, remember that since no, the heart is not capable to pump, okay, as a result of that, there will be an increase in the blood volume, okay, to fill the expanding ventricles to maintain the cardiac output. Thus, it can lead into what we call enlargement of the left ventricle. On the other hand, we have our diastolic dysfunction. Take note that diastolic dysfunction can also cause heart failure. Why? Because the heart ventricles, or the left ventricles rather, develops a stiffness. Why? Why is it developed? Why it develops no stiffness? Because it fails to relax. Okay, it fails to relax enough between contraction and proper filling is not achieved. Proper filling of the blood is not achieved. The possible causes of this diastolic dysfunction includes constrictive pericarditis, ventricular muscle hypertrophy, valvular heart diseases. Okay? Now, we have what we call digoxin. Okay? Digoxin is one of the most commonly used cardioactive drugs. Remember, it has two major actions. Number one is the positive inotropic response, which increase the force of the construction. Oh my God, the force of the contraction. I'm sorry. Don't laugh. Okay? Again, a positive inotropic response now increases the force of contraction. Okay? Contraction. And the negative kinotrophy no decrease naman the heart rate so that it can pump and it can contract properly. Again, these are the two actions, no, combined actions of what we call digoxin. Okay. Now, the use of digoxin, no, it is referred to be the digitalis glycosides, no, the digoxin and the digotoxin. Okay, they are used for treating moderate to severe systolic heart failure, not responsive to any diuretics and ACE inhibitors. Diba tandaan naman natin, kapag may hyperlipidemia, meron kang problema sa hypertension, it can also a factor of what we call heart failure. Okay? However, digoxin is not used for diastolic heart failure. Usually, for systolic heart failure. Okay, so these are the dosage of digoxin. PO means per orem or per oral. IV is intravenous. Okay. So for PO, for per orem, we have 0.25 to 0.5 mg followed by 1.25 milligrams Q 6 hours. Ano pong ibig sabihin ng Q 6 hours? Every 6 hours. Okay? Just for you to read. Yan na yun. Now, what about treatment for digitalis toxicity? Excuse me for a while. For digitalis toxicity or digoxin toxicity, it is more common to elderlies. Okay? It is common to elderlies. Why? Because it has a long half-life. Okay? The early symptoms of digitalis toxicity includes anorexia, no, and mild nausea. Anorexia and mild nausea is not common to drug toxicities kasi nami-misinterpret siya. But for digoxin or digitalis toxicity, it could be a early symptoms of toxicity. Aside from that, no, any change in the pulse rhythm, rate, no, in the central nervous system, such as mental status, orientation, changes in the color vision, hallucinations, or behavior are some of the manifestations of a patient experiencing toxicity to digitalis glycosides. Okay? For children, uh, detected ang ating toxicity if the patient experience what we call atrial arrhythmias. Okay? Electrolyte imbalance is also one of the side effects of this drug, which can affect our uh, potassium. No, it can lead into hypokalemia and hyperkalemia, as well as hypomagnesemia. For hyperkalemia, these are the drugs that we can use. Corticosteroids may be useful for hypokalemia. For hyperkalemia, heparin, no, beta adrenergic blockers, and mannitol infusions. Again, for hyperkalemia, we can use heparin, beta adrenergic blockers, as well as the mannitol infusions. For hypokalemia, we can use corticosteroids or butenamide. No, not butenamide. Uh, sige na nga, isulat ko nilang. Nasa na? Yun. Bumetanide. Okay? Butenamide for hypokalemia. So we have your butenamide, we have your corticosteroids for hypokalemia. For hyperkalemia, we have your heparin, mannitol infusion, and your beta adrenergic blockers. For hypomagnesemia, we can use ethanol or furosemide. Furosemide. Okay? Furo. Furosemide. Okay? Next in line is what we call the antimicrobial agents. Okay? Microorganisms can be found in our body, no? It can be in the internal or external environment. And as we all know, there are normal floras of our body. Let's say, for example, we have your Escherichia coli as well as your Streptococcus, no? We all know that Escherichia coli are the normal flora of our intestine, while our Streptococcus species can be found no, normally in our skin. Now, we have what we call chemotherapy. Usually, when we hear the word chemotherapy, the first thing that comes to our mind is no other than killing off cancer cells. The drugs, no, the drugs that is used for killing cancer cells or for cancer therapy. However, no, there is a newer classification or definition of what we call chemotherapy. Hindi na lang siya pwedeng sabihin na for killing cancer cells, but no, chemotherapy is now defined as a chemicals that is used for treating cancer cells, no, for treating cancer, and of course, infection. Thus, therefore, we can say chemotherapy as a cancer therapy or a chemotherapy of infectious diseases. Okay? You might heard the word antibiotics. You might heard the word antimicrobial. Okay? But what is the difference between antibiotics and antimicrobial agents? Take note guys that when we said antibiotics, these are produced by our microorganisms. Let's say for example, the penicillin. Galing siya sa penicillium, 'di ba? And when we said antimicrobial agents or antimicrobial, these are agents, synthetic or naturally, agents that can kill or inhibit the growth of the microorganisms. Okay? We have what we call also bacteriostatic and bactericidal. What is the difference between bactericidal and bacteriostatic? These are the mechanisms no of antibiotics or antimicrobial. Take note guys, pag sinabi nating bactericidal, okay? Bactericidal, it means that these agents can kill microorganisms. While for bacteriostatic, they are capable of what we call inhibiting the growth of the microorganism. Okay, so we also have what we call selective toxicity. What do we mean by that? When we said selective toxicity, it's the ability of the drug to kill or injure a target organism which is disease-inducing without injuring other cells within the vicinity or within the immediate vicinity. Remember that the property of antimicrobial agents no, is to be selective to toxic. Okay? And aside from that, no, uh, the differences in the biological hierarchy no, and other processes is critical for the survival of our microorganisms, no, thus can lead into what we call toxicity. Now, we have what we call uh, selective toxicity of drugs that are achieved in these ways. Number one, disruption of the bacterial cell wall, inhibition of an enzyme unique to bacteria, disruption of the bacterial protein synthesis, and the anti-metabolite action. Okay? Now, the classifications of antimicrobial agents can be classified according to the susceptible microorganism, and the sub-classifications are antibacterial, antifungal, antiviral, antiprotozoans, and antihelminthic. No? We also have the scope of drug action. It can be what we call the narrow spectrum antibiotics and the broad spectrum antibiotics. What do we mean by narrow spectrum? These are agents no, that can act against few species of microorganism. Ibig sabihin, specific, dun lang sa microorganism na yon. Kapag sinabi nating broad, from the word itself, broad, it has a wide variety of actions, wide variety of microorganisms na kaya niyang i-target. Okay? Remember, narrow spectrum antibiotics is generally preferred over our broad spectrum since kasi nga, yung ating narrow spectrum, intended na siya for, okay, intended na siya for our specific microorganism. Kung gram-positive, gram-positive. Kung gram-negative, gram-negative. Unlike broad-spectrum antibiotics, no, wide coverage. And of course, we have, based on the mechanism, the cell wall inhibitors, no, and when we said cell wall inhibitors, no, it weakens the cell wall of the bacteria. Example of cell wall inhibitors are the penicillin and the cephalosporins, no, which promotes the lysis of the cell wall that can lead into what we call death. We also have what we call increased cell membrane permeability, which allows the leakage of the intracellular materials of the bacteria. We also have what we call the bacterial protein synthesis inhibitors, an example of which are the aminoglycosides as well as our gentamicin. We also have what we call the DNA and RNA inhibitors, no? And these drugs naman binds directly, no? Kapag RNA and DNA inhibitors na, talaga matindihan na to na antibiotics. Why? Because yung sinisira na nila is yung the genetic material, no? It destroys or binds directly to the nucleic acids or enzymes for our nucleic acid synthesis. Example of which is yung rifampin, no? Another one is the metronidazole. Okay? And the other one is yung ating mga fluoroquinones. Example, specifically, ciprofloxacin. Okay? Is an example of an RNA and DNA inhibitors. Kapag yun na yung binibigay sa yung gamot, ang matindihan ng labanan nito sa mga microorganisms. We also have our antimetabolites, no, that disrupts the specific biochemical reaction that can lead into the decrease the synthesis of essential cells, no, of the uh, bacteria, no? Example of which is yung sulfonamides natin and your trinophtrin, okay? Trimethoprim. And lastly, we have your suppresses viral replication. Well, of course, no, this is capable of what we call the DNA polymerase, the reverse transcriptase, the protease, and the ano yung isa? Neuramidase. Okay? Take note that these drugs or that this agent, no, are needed for the replication and ineffectivity of the virus, of the viral load. Okay? Now let's discuss what is aminoglycosides. Okay? Remember guys that aminoglycosides, like what I've said a while ago, is a drug, is an antibiotic that inhibits the protein synthesis of the microorganism. It kills, no, the bacteria by inhibiting protein synthesis. And usually, okay, this drugs is primarily against gram-negative microorganisms that causes urinary tract infections, meningitis, wound infections, and septicemias. Okay? It is also recommended for the treatment of the nosocomial infections caused by Acinetobacter, Citrobacter, Enterobacter, Escherichia coli, Klebsiella, Providencia, Pseudomonas, Salmonella, and Shigella. Under aminoglycosides, we have what we call kanamycin and neomycin, which are both used for preoperative reduction of the normal flora of the intestine. Okay? Aside from that, there are side effects of our aminoglycosides, which includes ototoxicity and nephrotoxicity. Okay? When we said ototoxicity, that is the damage of the 8th cranial nerve. Okay? The damage on the 8th cranial nerve. Which is manifested by dizziness, tinnitus, and the progressive loss of hearing loss. Okay? That's the side effects of aminoglycosides in terms of the hearing because of the damage to the 8th cranial nerve. We also have what we call the nephrotoxicity. Okay? For nephrotoxicity, we have to monitor urinalysis and kidney function test, no? Because report, no, or because results, no, increase ng BUN and creatinine in the presence of cast means that the patient, no, experience aminoglycosides toxicity. Okay? The drug interactions of aminoglycosides include increased nephrotoxic potential, increased ototoxic potential, and neuromuscular blockade. Okay, so these are the doses of our aminoglycosides and the generic name. So ito po yung mga aminoglycosides natin. Amikacin, gentamicin, kanamycin, neomycin, metilmicin, streptomycin, and trombamycin. Okay? Trombamycin. And the dosage, no, given intramuscular and intravenous. So please be mindful of this one. Next in line is we have your cephalosporins. Cephalosporins are chemically related to penicillins. Like what I've said no a while ago, this these antimicrobial agents act by inhibiting the cell wall synthesis, like your penicillin. Okay, take note that cephalosporins are divided into four generations. The first generation, the second generation, the third, and the fourth generation. Remember, people, that when we said first generation cephalosporins, these are effective rather. These are effective against gram-positive microorganisms such as Staphylococcus aureus, Staphylococcus epidermidis, Streptococcus pyogenes, and Streptococcus pneumoniae. However, this first generation cephalosporins may have a mild action against some of our gram-negative microorganisms, which includes Escherichia coli, Klebsiella pneumoniae, and Proteus mirabilis. For our second generation cephalosporins, they have increased activity against gram-negative bacteria. Third generation cephalosporins has less active against gram-positive cocci and active against penicillase-producing bacteria. Kaya, kung yung mga bacteria is capable of producing penicillase, an enzyme, no? Yung mga beta-lactams natin na tinatawag, they might as well you give cephalosporins instead of penicillin. Amoxicillin, okay, is an example. And lastly, we have our fourth generation. Now, by the way, before I forgot, ito po yung mga bacteria, no, na pwedeng paggamitan ng ating third generation, Pseudomonas. Take note, ha? You can use cephalosporin, third generation cephalosporin, okay, against Pseudomonas aeruginosa. The bacteria, no, yung blue pus, no, blue rin siya sa kanyang culture media. And lastly, we have the fourth generation cephalosporin, which are broad spectrum with both effect against gram-positive and gram-negative microorganisms. Like what I've said a while ago, cephalosporins act the same as penicillin. That's why a patient that develops a reaction against penicillins, a patient may be prescribed with what we call cephalosporins. Side effects of these drugs includes diarrhea, okay, because some cephalosporins can alter the natural flora of the gastrointestinal tract. Secondary infections like thrush, genital and oral pruritus and vaginitis is common because of the resistance of the original antibiotic used. Okay? And then we also have what we call abnormal liver and renal functions. As we all know, siya ay mayroong nephrotoxic, na nagiging dahilan kung bakit mayroong abnormal renal functions. We also have increase, elevation or elevated AST, ALT, and alkaline phosphatase test, for our cephalosporin patients taking cephalosporins. We also have mali po yung spelling ko. This should be hypoprothrombinemia. Okay? Not hypopro. Nawala yung pro. Hypopro. Okay? One word lang. Hypoprothrombinemia. Okay? Which can lead into bleeding. Okay? However, pwede din walang naman bleeding. And we also have your thrombolitis and phlebitis, okay, which are recurrent problems associated with IV administration of cephalosporins. And lastly, we have our electrolyte imbalance. So these are the drugs under the first generation, second generation, third and fourth generation. Okay? Last but not the least is the vancomycin, no, which is capable of preventing the synthesis of the bacterial cell wall, and it is effective against gram-positive bacteria that may cause endocarditis. Sino po yung mga bacteria na yon that can cause endocarditis, meningitis, pneumonia, and septicemia? Take note, they can be Streptococcus, Staphylococcus, Clostridium, ano ngayon? Clostridium difficile, Listeria monocytogenes, and Corynebacterium. Okay? These are the microorganisms na pwedeng gamitin or microorganisms na may effect ang vancomycin sa kanila. Again, we have Streptococcus, Staphylococcus, Clostridium difficile, Listeria monocytogenes, and Corynebacterium. Okay? For the dosage per ORM, 500 milligrams every 6 hours or 1 gram every 12 hours. It can also lead into what we call severe nephrotoxicity and ototoxicity. Kapag po sinabi nating nephrotoxicity, okay, there can be a decrease in urine output and the production of the cast, as well as excessive RBC in the urine. Thus, therefore, it must be evaluated, no, or tested. A patient must be tested for renal function test, which includes BUN and creatinine. For ototoxicity naman, hearing loss, no, ang ma-experience ni patient. The next drugs that we are going to discuss are the anti-epileptic drugs. Okay? Remember guys, when we said epilepsy, that is a generic term. Now that refers to the group of neurologic disorders. Okay? Which are characterized by recurrent convulsive seizures, sensory disturbances, okay, abnormal behavior, and loss of consciousness. Take note, take note what I've said. It is a general term, a generic term for neurologic disorders characterized by recurrent. Ibig sabihin, pwede siyang pabalik-balik na convulsive seizures, sensory disturbances, abnormal behavior, and loss of consciousness. Now, what do we mean by seizure? Seizure indicate abnormalities in the central nerve centers of the brain. Okay? Aside from that, when you said seizure, it is a brief episode of abnormal electrical activity in the brain. Remember that seizure can be convulsive or can be non-convulsive. What's the difference? Kapag sinabi natin convulsive, violent, involuntary muscle contraction. Kapag sinabi nating non-convulsive, the other way around. Okay? Hindi po siya gayon. Mas kumbaga, mas relax yung contraction. O yung contraction. Okay? Kapag sinabi ng convulsive, violent, no? Involuntary muscle contraction. How about convulsion? Alam na natin si epilepsy, general term. Si seizure naman ay brief episode of abnormal electrical activity. How about convulsion? Kapag sinabi natin convulsion, it refers to involuntary spasmodic contraction of voluntary muscles throughout the body, which includes facial, skeletal, and facial and skeletal muscles. Okay? Now, in order for us to know if there is a abnormalities in our if there are neurologic disorders, no, a person may be observed in the hospital continuously using EEG, no? Ano po yung EEG? Hindi ECG ha, EEG. Electro, ang layo ng E. Electroencephalographic. Okay? Which is a video monitoring ng mga impulses, ng mga impulses sa ating brain. Okay? We also have the classifications of epilepsy. We have the grand mal or the tonic-clonic, hindi pala petit mal, the tonic-clonic. Okay? Which is most common, and the patients develop intense muscular contraction. We also have the petit mal, no, which occurs in children, okay, and characterized by paroxysmal episodes of altered consciousness. We also have psychomotor, which is an aimless wandering, usually repeated chewing, lip smacking, and swallowing movements. And we also have your Jacksonian type, which is a localized convulsions of the voluntary muscles. Okay? So anti-epileptic drugs are used to control and prevent seizures while maintaining reasonably comfortable quality of life. However, our anti-epileptic drugs have many side effects. Okay? Examples or classifications of our anti-epileptic drugs includes number 1, barbiturates. Barbiturates elevates the seizure threshold and prevents the spread of electrical seizure. No? Prevents the spread of the electrical seizure by enhancing the inhibitory capability or effects of GABA. Remember guys that we have our long-acting barbiturates, which includes your mephobarbital and phenobarbital. Okay? These are all effective against convulsion or known as an effective anticonvulsants. Okay? Why? Because of their sedative effects. Thus, it can be used for treating partial and generalized tonic-clonic seizures. Okay? So for mephobarbital, the dosage is 400 to 600 milligrams per day, and that is recommended or used for grand mal or petit mal seizure. For phenobarbital, we have 100 to 300 milligrams per day, which can be used for all forms of epilepsy. On the other hand, we have our benzodiazepine, which inhibits neurotransmission by enhancing the effects of GABA in post-synaptic clefts between our nerve system or nerve cells. Remember, we also have your clonazepam. No? Clonazepam is useful in oral treatment of the absence, akinetic, and myoclonic seizures in children. No? And it is given up to 20 milligrams per day. We also have your diazepam. Diazepam must be given IV to control seizures. No? And diazepam is recommended for all forms of seizure. However, since it is given intravenous, dapat slow administration at the rate of, take note of this, at the rate of 5 milligrams per minute. No? 5 milligrams per minute. Yan. 5 milligrams per minute, no? Diazepam IV. Next in line is we have the mood disorders. Okay, the drugs for mood disorders. So what do we mean by that? When we said mood, no? These are what we call sustained emotional feeling perceived along continuum SAD, no? And when we said mood disorders, it is an affective disorder characterized by abnormal feelings of depression or euphoria, resulting into an impairment of the person's or individual ability to function for a certain length of time. Kaya sinasabi ng iba, wala pa ako sa mood mag-aral. Okay? Pero hindi naman yun mood disorder. Now, uh, mood disorders can be divided into two. We have the depressive or unipolar, and we have the bipolar disorder, the bipolar disorder, or what we call the manic depression. Okay? Types of depression includes mild depression, severe depression, and moderate depression. What do we mean by mild depression? Mild depression involves mild symptoms, no, and minor functional impairment. While severe depression reduce behavior symptoms that can lead into the impairment of the performance of the person's daily activities. And when we said moderate depression, exhibits moderate, no, or intermediate sensitivity or intensity, no, immediate intensity. Saan? Uh, in the functional impairment and symptoms. Okay. Now, what are the drugs for mood disorders? We have the monoamine oxidase inhibitors. Monoamine oxidase inhibitors blocks the metabolic destruction of norepinephrine, dopamine, and serotonin by monoamine oxidase. Remember that this, no, drug increases the concentration of these neurotransmitters. At ano yung mga neurotransmitters na yan? Ito yung ating mga norepinephrine pong iyan. Okay? Remember that monoamine oxidase inhibitors, no, is used for to elevate, no, or elevation used for elevation of moods and reduced symptoms of depression. However, there are side effects of mouse. At ano po yung side effects ng mouse? Mild orthostatic, hypotension, and drowsiness. Sometimes sedation. No? Examples of MAO includes the phenelzine, tranquilizopramine, and isocarbozazid. Okay? Next in line is we have the SSRI or the selective serotonin reuptake inhibitors, which are widely used against depression. Why? Because they don't have cholinergic and anticholinergic and cardiovascular side effects. Okay? Again, it is used for the elevation of the mood and reduce symptoms of depression. Side effects of SSRI includes restlessness, agitation, anxiety, insomnia, and sedative effects. No? Sometimes gastrointestinal effects may also be observed. Example of SSRI are the citalopram, fluoxetine, fluvasamine, and the paroxetine. Okay? They are just the examples of the SSRIs. We also have your tricyclic antidepressants. Take note that tricyclic antidepressants, no, prolong the action of norepinephrine, dopamine, and serotonin by blocking reuptake of these neurotransmitters into the synaptic cleft between neurons. Okay? Examples of these drugs are the amitriptyline, amosapine, clomipramine, desipramine, desipine, and imipramine. Okay? We also have the lithium, no, which is a monovalent cation that competes with potassium, calcium, sodium, and magnesium ions, two cellular sites no, sensitive to change in our cation concentration. Okay? Remember that lithium is commonly referred as a drug for bipolar disorder, no? And that is anti-manic, no? Anti-manic agent for for adults. Ito yung sinasabi natin for bipolar disorder. Okay? Aside from that, no, lithium replace intracellular and intraneural sodium, thereby stabilizing the neural membrane. Okay? It also releases or reduce the release of norepinephrine and increase the uptake of tryptophan, the precursor of serotonin. Okay? Side effects of using lithium as a therapy for mood disorder includes nausea, vomiting, anorexia, abdominal cramps, okay? Excessive thirst, urination, and tremors. Remember guys that a patient reported with these signs and symptoms or manifestations, no, must be addressed accordingly. Aside from those side effects, persistent vomiting and profuse diarrhea, okay, lethargy and weakness are some of the adverse effects that needs to be reported to the clinician. Okay? And severe side effects or adverse effects of lithium includes progressive fatigue, weight loss, or weight gain rather, progressive fatigue, weight gain, pruritus, ankle edema, hyperglycemia, and nephrotoxicity. Okay? That concludes our discussion about therapeutic drug monitoring. Thank you, stay safe, and mabuhay ang lahat ng medtech na hindi sumusuko.